Can you all hear me?
Yes, sir.
Yes.
Yes, sir.
Perfect. Sorry for running just a little bit behind here I got a new audio system and it's not playing very nicely with my computer. It was until I got the Windows 11 update or whatever it is. Anybody else get that? No, I'm just the only nerd here. That's cool, guys. I don't believe that, first of all. Bunch of grad school students. Well, how is everybody tonight?
Good.
Good.
Awesome. Well, we will get going here very quickly. Tonight's going to be about an hour long, and I've got another class at 6 that I'm teaching, and I'm going to be covering tonight just kind of the general expectations for the course and what the 30-page paper is all about. And I'm just kidding, guys. I'm not making you write a 30-page paper. Gosh, I'm not reading 30 pages. I used to do a lot of papers in my classes, but I've discovered that you guys are a lot like me whenever I was in grad school, and as passionate as I was about all these topics, writing papers was still just the last thing I wanted to do. And so usually when the class is smaller, when it used to be smaller, I would teach it and we would have 2 or 3 papers. Yeah, but I'm not going to do that this go around. Let's see. So I am, for those that don't know me, I am Dr. Armstrong, and I am a full-time professor of counseling here at Amberton, and I've been here for, I guess, approximately 8 years at this point. And with teaching full-time here, let's see, I was the department chair for a year or two, and then worked on different behind-the-scenes projects with trying to get our courses in line with the new state laws going through. And I've taught this class since the very beginning, whenever it was initially dysfunctional behavior. And prior to the new law in the state where they jumped from 48 hours to 60 hours in your master's program, we just had one class called dysfunctional. It was my dysfunctional class. That's what I always used to say. And it was a combination of this class, the adult and geriatric psychopathology, and the child and adolescent psychopathology. And it was just, quite frankly, too much to try to get through in one semester. So they asked me to split that course up into 2. And you are on the adult and geriatric side. Not personally, I don't know you personally, but in class, this is the adult and geriatric psychopathology course. And you will, if you haven't already, take my child and adolescent. I see quite a few familiar folks. So what my practice is outside of Amberton is as a neuropsychologist, and I specialize in the brain and understanding how the brain functions and develops. And when something goes wrong with the brain, both the psychopathology of that, but also the underlying neuropathophysiciology and various biological syndromes. I've worked a lot with, starting out with sleep disorders in grad school. If you ever want to study something that's very difficult to stay awake for, just study sleep medicine. I've presented at conferences for sleep medicine, and I promise you the crowd that's there are just as exciting as it sounds. With that being said, I used to test people both from a psychological and a neuropsychological standpoint prior to the treatment of sleep apnea. And the worst job I've ever had in my life was watching people sleep at night in a sleep study. We'll talk a lot about sleep apnea in this course because that's something that's going to come up quite a bit if you're going to work with adults. And then from there, my training went toward, I would say, general neuropsychology, adult, and then also forensic in my postdoc the next 2 years there, whereby towards the end, I started working a lot with schools. And so I've kind of had both the pediatric and the adult side of training on neuropsychology. And if you're wondering what neuropsychology is, it's essentially the science and study of and use of various psychological and neurocognitive tests to measure underlying physiology of the brain. So I've worked a lot with brain injury patients, a lot with stroke and dementia. And in fact, neuropsychologists, including myself, tend to be the first person to communicate a diagnosis of like Alzheimer's to a patient and a family. And it's not my favorite part of my job, but at the same time, as a counselor at heart, I feel like I'm well equipped to do that in a manner that that those folks deserve. And we typically spend a lot more than just the 50 minutes in those hours, where I get an opportunity to kind of help them take the next practical steps after that diagnosis and make sure that I'm connecting them with any referral sources that I have, kind of beginning the process of grief, the processing of grief, and then ensuring that I follow up later on. So with all that said, I've been in practice for, let's see, I was licensed in 2013, I think, or 2014, one of those years, and had a practice up in Paris, Texas, and then ultimately opened a practice down here in Wiley, which is where we live, and had 2 going at the same time. And thankfully sold my Paris practice to my old resident as of May this year. And now I'm here at my practice full time. And my wife, Leah, she is the COO of the practice and does all the business stuff. She makes sure we get paid. I have a tendency not to want to charge people stuff, but can't really run a business like that. Thankfully, she's a little bit tougher than I am in a therapeutic way. And then we have a 7-year-old and a 4-year-old at home who keep us very busy and awake at all kinds of hours of the night. And 2 dogs, Rio, Burrito Armstrong, this is literally his registered name, Rio Burrito, and Lucy, who we call Lucifer sometimes. I am passionate about the brain. I'm passionate about this class, and I'm excited that you're here because this is really where, as a prospective counselor, this course is going to set you apart in training well beyond essentially all physicians out there except for psychiatrists and mental health. Okay? Because they didn't take this class. They don't take a course like this in most cases. I'm telling you that because the Texas Medical Association, TMA, actually not once, frequently has attempted to take away your ability to diagnose and try to take that out of your scope of practice as a professional counselor. And they wanted essentially only physicians to have that ability to make a diagnosis, so that everybody who needed counseling and wanted to use their insurance would have to go through a physician first to get a diagnosis of a mental health disorder and then get a referral to a counselor. Can you imagine the barrier that would be, where everybody had to go through their primary care or their pediatrician before they saw a counselor? And that was their goal. And you can bet that they're going to go after that again at some point, and which is unfortunate. But I want to highlight that's importance, because for this class, our goal and our objective is to learn how to use the DSM-5 and provide and perform a differential diagnosis. And we'll talk about what that means later, but essentially a diagnosis is the foundation from which medical necessity is rendered. And ultimately, that's where you're going to defend yourself in front of a state board if they ever called into question, why are you providing counseling? Now, I am an existential humanistic counselor in my other life, which means that whenever I provide counseling, that's the theoretical framework that it's my foundation. And so I'm right there with most folks, where we kind of wish there weren't diagnostic labels, and some of you may even be against making diagnoses, and that's completely okay. I would just ask that and encourage you to hang in there with me this semester, because even if theoretically you don't believe in the diagnoses, and there's some debate, both for and against there, it's still the kind of gold standard language that we use clinically to communicate what's going on. And I'll even encourage you and let you know that you can make diagnoses as an integral part of your practice clinically and make it therapeutic, I promise. People worry that it's going to put a label and stifle folks or prevent things from happening, but the reality is that most of these, well, not most, all of them are biologically driven. Every diagnosis in that purple book that we have is biologically driven, and because of that, there's a separation or a degree of separation between that which is me and that which is my disease. Unfortunately, there's a stigma in mental health because that separation hasn't always existed. And so when people say, I'm depressed, that means that there's something wrong with them personally, as compared to looking at it from a biological disease standpoint. And I can promise you, you can cause a chemical depression through a seizure, through brain injury, through stroke, if you hold your breath long enough and pass out. There are ways that our brain is shaped by external factors beyond just our psychology. And in most cases, depression comes from a primarily biological origin. And that's just an example, but for this class, we've got an online format that is going to be, I would say, both a challenge and maybe a blessing in some ways, where you've got a lot more flexibility than a typical course here, and being able to work your way through the course material. This is the weird semester where we go 2 weeks and then we're out for 2 or 3 weeks, whatever it is, and you come back and you forgot you were in school until you get an email from me, and then you're like, oh, don't even remember anything we've talked about. This class gives you kind of a surface level scoop like a single scoop. So I always wanted to say, I'm hungry right now. A single scoop of diagnostics. And in that, you're not going to have time, or really, I would say the neurological capacity to absorb every bit of information that you really need from this course. I promise you, I have not read the DSM-5 word to word, but I promise you, whenever I have insomnia at night, that's when I try to read it word for word, because it's a very effective treatment for insomnia. That's a joke, folks. Also, bonus points if you laugh at my dad jokes. That's another rule of the course here. But you're not going to have time to read through the whole thing, and that's okay, because even by the time you did, let's say you did this whole semester, by the end of the semester, there's half of that's going to be modified because of the new science that's come out. Okay, and so there's a dynamicity of what we're learning here. And my hope is to be able to bring in extra materials beyond the DSM-5 that helps kind of speed you up to where we think science is at the moment. Okay. With all that said, I want to go over the course syllabus real quick. And I hear you, Michael, not the only one to fall asleep while reading the DSM. So we'll go over the syllabus, talk about the assignments and the discussion questions for the course, kind of the general outline of what our meetings will look like from here forth, and then probably get into talk a little bit about the biology behind all the stuff that we're going to be talking about. If this is your first time ever hearing some of these words when it comes to the neurobiology and the neuroanatomy that we're going to talk about, and neurotransmitters, things like that, don't let it intimidate you. Just sit there with your eyes like glazed over, but just absorb it, because I promise you, we're going to recover, we're going to rehearse and review, and you're going to hear all this stuff a million times between now and the end of the course, and especially between now and the end of your program. All right, so I'm going to pull up your syllabus. So the best way to get in touch with me for this course is to email me at the Amberton email, which is the Gmail account. I don't mind you send me messages through Moodle, but to be honest with you, it's a lot more challenging for me to reply quickly through Moodle, because I have to log into Moodle on my phone and then go to the messages, and Moodle's servers are always taking like 10 years just to switch pages. Does that ever happen to anybody else? Moodle's real slow all the time.
Yes.
Yeah. Yeah, I once just stood there for like 5 minutes while like a half a PowerPoint slide uploaded, and then as soon as it did, it kicked me out. Because of that, if you could email me at that email address, my goal here this semester is to get back and respond to everybody within about 48 hours. I wish I could be quicker than that, but you've got to hopefully give me a little bit of slack and cut me some grace here, because I've got the biggest classes out of all of Amberton, typically between 120 and 130, whereas most professors have about 40 to 60. And unfortunately, there's a lot of folks in your courses that either don't read my emails or don't read any of the syllabus, assignment guides, things like that. So I get a lot of the same questions over and over again. And I'm trying to get better at getting to those and being gracious in my response. If you don't get a response from me, it's one of two things. Either one, your message got buried, and I haven't either gotten to it, or it got buried and I didn't see it. Or I've already answered your question and I'm kind of passive aggressively making you go back and reread all your stuff. Okay. It's not really passive aggressive as much as it's going to save your time and my time if you make sure that you read through my emails and the syllabus prior to sending any assignment related questions. Feel free to nudge me, hit the little nudge button on the Gmail account there as much as you want. It's not going to bother me, I promise you. And I especially really enjoy answering questions related to the content more so than just answering, when are things due. Let's see. So I would rather you email me instead of call. You can call. I just kind of let you know I've been here almost a decade and I still really haven't figured out how to check my voicemail all that well. I'm pretty sure I kind of remember how, but I don't remember the last time I did. It's just really too cumbersome at this point. For the class, you're going to need our purple book, which is the DSM-5. And if you didn't buy it or you're just trying to rent it, I understand because it's pretty expensive, but you're going to need this thing even beyond grad school in most cases. So as far as reading goes, we're going to kind of start at the very beginning of this thing. And I would encourage you to read through up to the point of the class so that like if we're in, I think week 2 is neurodevelopmental disorders when we start talking through that content. Let me make sure that's right. Yeah. Week 1 and 2. And you want to make sure that you've read up to that, to the end of that section there. Again, don't try to read this thing word for word. I'll give you just a strategy is for the sake of your brain and getting it in there, the important information, there are some sections that are more important than others. With the DSM for each diagnosis, what I would recommend reading is the diagnostic criteria. I'll let y'all write that down. So I want you to read the diagnostic criteria, the development and course section. And that section is basically talking about what does this diagnosis look, how does it look different across the lifespan. The differential diagnosis section and then the comorbidity section. Okay. Now, I'm not saying you shouldn't read all the rest of the stuff, but if you were going to just highlight and focus here, focus your time, make sure you read those sections. And if you have extra time, go back and read all the tiny details in between. And the big thing is that you just need to know where to find the information mainly, because for this class, you're not going to have to memorize stuff off the top of your head as far as specific diagnostic criteria, things like that. Give me 1 second. I'm going to shut my fan off here because it's kind of chilly in my office. Just a second here. All right. So is everybody good with the reading? Understanding that?
Yes.
Awesome. So you'll see that we've got, for this class, we've got, let's see, 3 grades. And we've got a midterm which is about 40 multiple choice questions, and a final, which is the same. And the final exam is not comprehensive. The final is going to cover the topics covered from weeks 5 through weeks 9, basically. Both of those exams are going to be offered in Moodle, and they will be open for at least a week, if not longer. For both of those exams, I'm going to give you 3 attempts to take it. And I'm going to either average your best score. I'm sorry. I'm going to average your 3 scores, or I'm going to take just your best score. I haven't decided yet. But you'll have 3 attempts for each test. If you make 100 on the first attempt, you don't have to take it again, by the way. I mean, unless you just enjoy taking tests. But that's going to be 80% of your points here for the course, where you've got a final exam and a midterm. And week 3 and week 8, I'll make sure, if they're not already posted, I'll make sure that you actually have access to all the questions that you're going to see on the exams a couple of weeks ahead of time. So people say, well, that's really too easy, Dr. Armstrong. I came to grad school so that I could stress out more. The reality is that I'm trying to get this information into your brain, and the vast majority of you folks, y'all would do just perfectly, even if we didn't have any grades and we just like did a pass fail kind of a deal where you made it through because you try so hard and you put so much effort in there. And if I can design a system to where you're having to rehearse this information over and over again, while rewarding you for doing so, at least in efficiency of completing the exams, ultimately, that's, I think, the best way to learn, because I'm not here to fail anybody. And I've only had to do that just a handful of times. And most of the time people fail my courses anyway, just because they just stop like either coming to class or trying. As long as you're putting effort here, I'm willing to work with you. If something happens in the midterm, or, let's just say that things are going perfect and the final exam week comes up and you had it planned, and then all of a sudden life happens and you're worried about failing the class, I promise you, I'm not going to let that happen. We will work with you guys, and in that event, we would have an incomplete, just give you some extra time to get it done. But you need to communicate with me as swiftly as possible, if you can, when things happen, so that I can be as flexible as possible. Okay. The other 20 points for the course will be in your discussion questions, and these are weekly discussion questions where, let's see, for each week, I have questions that you're going to review and you're going to answer. And I can see quite a few of y'all have already done that, which is awesome. And at the end of this thing, and it is at the end, I will have you end up telling me how many you completed, whereby I'll go back and double check, make sure you're telling me the truth. Okay. The discussion questions aren't there just to do busy work. They're there to try to give you a little bit more depth and direction. They are obviously just a completion grade, as if you were attending class, but for each one you get, I think, what is it, 2 points per week. And if you take the midterm and the final, you get 2 points for the midterm and 2 points for the final, because we don't have discussion questions those weeks. All of those are due by the end of the course, the very last day of the class. Y'all will still email me about, week 7 is when people start getting worried and saying, when are all these due again? It's at the very end of the course. The week 1 discussion question, if you haven't already, you need to complete that because I've got to take roll with that and turn it into the registrar. And I think they track you down or something. They show up at night and then knock on your door. I don't know. I don't know what they do. I think they will contact you to make sure you want to stay in the class. They won't drop you if you forget to take or if you forget to do the DSQ, but they'll just want to make sure that you're still wanting to stick around because they're trying to do some risk prevention on the front of how much refund they have to give you. Okay. All right. It's a lot of information, folks. Any questions about any of that?
I have a question.
Yeah.
So on Moodle, there's like those cases that you want us to read through and there's questions for them. Is that just for us? We don't need to turn that into you?
Right, that's correct. And so if you come across language that says like your case vignette is due, things like that, I've tried to clean it all up because some of that stuff carries over from class to class and I change stuff and modify things sometimes. And don't worry about it if you come across that. That's basically for your own practice. I will send out an email. Most weeks, you'll get at least 1 email, if not 2 from me. And if we're going to go over anything in our time together through Zoom, I'll let you know ahead of time. Yeah, but none of that's going to be for a grade.
Thank you.
Mm-hmm. Yeah, there we go. I see what you're saying. As far as the schedule for Zoom, I've really gone back and forth here on wanting to offer a weekly class where we meet for at least an hour, if not longer, and go through all this information together. I'll say this is that that would be the ideal here. And I think in the long run, that's what we're going to probably land on as a university. As it is right now, the courses that I teach tend to be the largest, and just from a responding to email standpoint, I've tried to balance the pure online courses with giving you some recorded lectures as I can. And like I said, I just bought a brand new audio recording system that I think is going to help a lot. Because my goal here is to be able to offer more recorded lectures that you can watch and rewatch, rather than us trying to find time that makes sense for everybody to meet, because many of you guys are also taking other classes that meet all different times, and there's no way any of us professors know when y'all are meeting. And so it's just been a challenge. But I will try to let you know a general outline of that schedule within the next couple of days, of the specific days that we will do the optional Zoom meetings, and they will be optional. We won't judge if you don't come, and they will be recorded so that in case you miss one, I will upload it and you'll be able to watch that later if you'd like. We're going to probably shoot for about 4 to 5 Zoom meetings over the course of this semester, just so you know. We won't have any over the Christmas break. I would encourage you during that time to just turn your brain off. I know all the professors are out there like, well, you got to read all this stuff. You're going to have plenty of, like, the rest of your life is going to be filled with stuff. Just take a break. Even those high achievers out there, just take a break over the next few weeks and just let your brain recoup and recover. And if family members ask you if you're analyzing them, stuff like that, just tell them you're taking psychopathology, and of course you are, and you don't work for free, okay? All right, any other questions? We will get going then. Let's talk about the brain for about 15 minutes here and see if we can cover like a crash course of neuroanatomy and neurobiology, and hopefully make you feel a little bit more confident about some of these terms that we're going to come across. Let's see. And I forgot to mention it a while ago, so a little bit different for me as compared to my as compared to most psychologists out there is I have an additional postdoctoral master's in clinical psychopharmacology, which was the first 2 years of med school, where we took those same pathophysiology courses, biochem, all kinds of stuff, general pharmacology, alongside first and second year med students. From there, we took a class each for each class of psychotropic medication, after which we graduated and then and/or went on for a year-long preceptorship where we prescribed under the supervision of a psychiatrist for a year. And then we've got like a certifying exam at the end of that. I don't prescribe because I can't in Texas and probably won't ever be able to, just because Texas is a little bit behind the times. I can prescribe in other states, and mainly I got that training so that I can consult with general practitioners and pediatricians who tend to be the #1 prescribers of psychotropic medication. Additionally, I, as an expert for the courts, will often testify on psychopharmacology, and probably the #1 thing I learned in all that training is how underutilized counseling and psychotherapy is historically when it comes to mental health disorders, and how overutilized and incorrectly utilized, unfortunately, many of these medications are for psychiatric syndromes. And so I don't know everything there is to know about the medication side, but if you have questions on that front, we will definitely, I would love to talk about that. We'll talk a lot about the medication as we go, but we'll also cover quite a bit of just the general recommendations for treatment for the various disorders. So for this course, let me see. We're going to end up covering all of these diagnostic categories here. And compared to the child and adolescent course, we're going to focus on a lot of the neurocognitive disorders, personality disorders, and the substance-related disorders as well. But we will definitely still talk about all the other stuff. It's just that for this course, we tend to spend more time towards the end of this book rather than the beginning. And that actually is designed that way, and where they wrote this DSM-5 and they put the chapters together in order, mainly from an intent to identify the most common syndromes seen or that begin in childhood versus those that tend to begin in adulthood or later, which is why personality disorders are towards the end, okay? And just real quick, let's talk about what a differential diagnosis is, because you're going to hear that word a lot. A differential diagnosis is kind of a weird term where it's both a verb and noun. So it's a verb in as much as it's a process through which we arrive at our final or best guess diagnosis by ruling other stuff out. Now, it is a noun because the diagnosis that you land on as a result of a differential diagnosis is often referred to as a differential diagnosis. So a lot of people will say, you'll hear it on TV all the time, it's like, doctor, what's your differential? And they'll just say one diagnosis, and you're like, whoa, that's not right. But what they're meaning there is, what did you conclude as a result of your differential diagnosis? So if I said, I had a patient that was, 45 years old, reporting difficulty concentrating, low mood most days, feelings of hopelessness, some passive suicidal thoughts, low energy, low motivation, and then feeling really anxious and geared up. Well, we're obviously talking about possible depression there, but as a part of depression, we're going to be ruling several things out, including the medical syndromes like, vitamin D deficiency, the hypothyroidism, to the psychiatric side, where we're going to be ruling out things like generalized anxiety disorder, which often goes hand in hand with depression, as well as trauma disorders and so forth. So that is the process of a differential diagnosis. And we'll talk about how to do that for each of these disorders. Let's see. And we'll probably spend about 5 more minutes just on this slide for tonight. Our subjective experience psychologically is the product of the most complex system working together as far as we know. In other words, the human brain is the most complex system that has been identified in the whole universe, because there are literally trillion of connections within your brain between all the neurons and dendrites and axons that are out there connected to each other. So just a few things that you need to remember as it relates to the brain and psychology is that at some point in your career, maybe it's this class or you've already done it, or maybe down the road, you need to ask yourself, what do you really believe that the brain does in relation to you? Now, there's folks that land on the philosophical side of that or the spiritual side of that. And I have, my own spiritual beliefs as a Christian. But then there's also folks that land pretty, solid and I would say concretely on the biological side of that. And there's all in the in-between. If I can encourage you is that it appears that there's no one right answer. And that anytime we try to pick apart and land on one side or the other side is often left out. And when you do that, you're missing a core component of what we would define as psychology. Now, the brain is composed of gray matter and white matter, and you've got gray matter on the outside of the brain, and it's the little neurons, the little teeny tiny brain cells that are the processing centers of the brain. And you can think about each neuron as being essentially like a little laptop, just, by itself. And when I say by itself, our neurons are not connected directly to other neurons. They are in isolation. They are islands for within the overall matrix of your brain. The way they communicate, or the wires that connect those computers, is the white matter. Okay. And so most neurons have one side that's like a receiving side, and then one side that's a sending side of a message. Although there are some that go back and forth and all kinds of which ways. And in fact, what we're discovering now is that neurons aren't the only cells in the brain that are communicating. Even the support cells, the glial cells, which used to be just they thought was just a skeleton for the brain holding up the neurons, or actually play a crucial role in neurotransmission. As it relates to psychopathology, it's impossible to make the argument in most cases that there's nothing wrong with the brain and that this is just psychology. And I'm saying that because that might seem like well, of course, but you'd be surprised when you haven't reflected on your own beliefs there, especially as it relates to you. And that's the important piece here, because I'll tell you, I was diagnosed with ADHD when I got to grad school, and despite focusing on this stuff and specializing in it, and even working with all kinds of kids with neurofeedback and neuropsych, diagnosing and testing ADHD, I didn't believe it applied to me for whatever reason. At least I was in denial for a bit, and I wrestled with it so much and I got angry about it that I really got through into the depths of neurology behind it and really understood it to be a pure neurological syndrome. And I always kind of make the joke with my patients is none of us woke up one day and was like, you know what, my life is too easy. I think I'm going to have some depression. I've never met a person in my life that said, you know what, I think I'm going to be ADHD. Just do the extreme living. In other words, it wasn't a choice. And if most people had a choice, they'd have the perfect healthy brain, which in turn would cause us to have no psychopathology. For this class, what you need to remember is that we've got some beliefs about some of this stuff that seem to land more on the psychology side rather than the neurology side. And I want you to challenge yourself to kind of try to be aware of that and do your own research there and come to your own conclusions. The last thing I'll say, because I'm going to have to wrap this up, unfortunately, is that our brains use chemicals to communicate between those neurons, and the specialty of psychiatry and medicine is the specialty that focuses on modifying those neurotransmitters through medication and other means that are within their scope of practice. Medication or psychopharmacology and psychiatry comes from just this weird, like Freudian, like hazy background that used to be a lot more psychological than nowadays. But if you've met any of the newer psychiatrists that are recently graduated or within the past decade or so, most of those folks are pretty aware of the importance of understanding the science behind these things. Yet, what we know today is not necessarily what's going to be true tomorrow. And so you need to keep an open mind when it comes to us determining, like, hey, with depression, we know that serotonin, for example, is low, just to put it in a simple term. And that if we had enough serotonin, we wouldn't be depressed anymore. Well, that's an oversimplified way of saying it. And in general, that's not necessarily a bad way of saying it. But since the serotonin theory kind of first came out, it's been modified about 1 million different ways. And we've gotten more specific in what we mean when we talk about serotonin in relation to depression, and to the point that medication in psychiatry has had a hard time keeping up with it, because this stuff is not easy to treat. Long story short is that the science is pretty clear that when you combine an accurate diagnosis with the right type of medication as prescribed by a specialist that knows what they're doing, with the right type of counseling specialist that knows what they're doing, and they work collaboratively, you get a synergistic effect of treatment outcome that you wouldn't otherwise get from either one by itself. And so I'm not saying that all of these diagnoses require medication, but most of them could benefit from the right type, and especially if we were looking at combining it with the ideal therapist. Okay. All right. Any questions? It's really hard to talk whenever everybody's talking over each other. Well, if there aren't any questions, no big deal. Not going to hurt my feelings, but I'll say this is that I really hope you guys have a Merry Christmas. And this coming week, I'm going to send out a kind of the outline and specific dates for our Zoom meetings. And in the meantime, feel free to email me. If you email me over the Christmas break, there's a good chance it's going to take a little bit longer than 48 hours to get back to you. Mostly because I'll be either sleeping or playing with my kids. So there's nothing else, then we'll wrap it up for tonight. And this was recorded, and I'll make sure I get this uploaded tomorrow to Moodle for those who couldn't make it tonight.
Dr. Armstrong, I actually have a question, but it's not about what we talked about tonight. It's about some specifics with ADHD related to a specific scenario. I don't know if that's something you'd rather me schedule to talk to you about it another time, or.
Yeah, if it's a fairly quick question, I could spend just a few minutes on it. I'd be happy to.
Well, my big question is, I'm dealing with a child that has ACC, and I'm wondering, so that would, I'm trying to understand, like we talk about differential diagnosis. He has mild ACC. A lot of his behaviors are the behaviors that we're looking at in ADHD, and I understand he's a child, and that's child psychopathology, and we're in adult psychopathology.
And when you say ACC, agenesis of the corpus callosum, correct?
Yes, sir. Yes, sir.
All right.
And so I was just curious, does the ACC prevent the diagnosis of ADHD, or would the ADHD be in addition to comorbid with the ACC?
Yeah, and that's a really good question. And actually, it applies across not just to that specific situation, but across the rest of the stuff that we're going to talk about for the course, is that most of these diagnoses are not direct etiologies by themselves. In other words, in that case, there's no doubt that the agenesis of the corpus callosum has modified the brain to the extent that this person is displaying what would otherwise be classified as ADHD symptoms, and but it's clearly caused by the ACC. They can still be diagnosed and should be diagnosed with ADHD regardless of etiology.
Okay.
Yep. Now the difference would be is if you had somebody who was 50 years old, had a brain injury, and then had ADHD symptoms afterward, you wouldn't make a diagnosis of ADHD at that point, because ADHD is a neurodevelopmental disorder that has to be present during the neurodevelopmental time frame. And that's a generic way of saying between essentially conception to age 25. after which, if you have an injury that declines that causes ADHD symptoms, it becomes a neurocognitive disorder at that point. And in that case, it's going to be probably neurodevelopmental disorder due to agenesis of the corpus callosum. And there might be even an underlying genetic syndrome that caused that, by the way. In most cases there are, where you also are going to have a diagnosis of ADHD that goes along with it.
Okay, great. Thank you.
Yes, sir. Well, all right, folks. Well, I'm going to switch over to my other class here, and I will be on the lookout for your emails, and looking forward to a great semester. All right.
Have a great holiday. Thank you.
Y'all have a Merry Christmas.
Thank you. Merry Christmas. Bye-bye.
Bye-bye.